Hello, welcome to HFMAtalk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In this episode, we're looking at the role of the air ambulance and how this service interacts with the NHS. So I'm really pleased to be joined today by two stalwarts of the Dorset and Somerset Air Ambulance, Chief Executive Bill Sivewright and Medical Lead Dr Phil Hyde. So thank you both for joining us. Bill, I wonder if you could start us off by giving us a bit of an overview of the organisation.
It's quite a small organisation in charity terms, in that the charitable team is quite small. It's around 15 whole-time equivalent staff. But the clinical side, which of course is the focus for our efforts, is considerably larger. It now numbers 43, and that includes a mixture of clinicians, practitioners. That's a blend of nurses and paramedics, doctors, and nurses involved in patient and family liaison, not just critical care, and we'll probably get into that a little later. And of course, our aviation specialists. We've got now 10 pilots and an aviation engineer. So it's quite a large team at our airbase in Henstridge.
And Phil, you're the medical lead, but you also work within the NHS. How does that work together for you?
Thanks. Really well. And I suppose it would be important for us to say that Dorset and Somerset Air Ambulance is a charity and is funded by the public, and all of the clinical activity that it supports is governed by the NHS. And so when you ask the question, you work in the NHS and then you're working for the air ambulance, then I actually am working for the NHS clinically all of the time. I work for the NHS. I happen to be funded through central funds, through NHS funds, in half of my time working in the hospital, and funded to do NHS clinical work by a charity in the other half of my time.
And I think that brings us on quite neatly to the funding actually around air ambulances. I always assumed that the NHS would partly fund or fully fund the air ambulance, but that's not the case, is it, Bill?
No, it's not, and our statement is that we are not directly funded. We receive no direct funding from the government in any form. It's really unfair on our local ambulance service to say that we get no support, because of course in the form of just over seven paramedics are gifted to us in effect by the ambulance service as part of a service level agreement that we have with them, as well as all the mechanism and the governance mechanism that sits there also supporting us. So it's not that we don't get support from the government through the NHS. It's just that it's not direct funding, and so all our funding we require to raise through a variety of means, directly from donors, through our own lottery and so on, which amounts to, just for the operational aspect of what we do, around £7 million a year. I think the independence is important because it means that it makes us a more agile organisation than any arm of the NHS could be, because merely on a point of scale, when we decide that a particular piece of equipment or a drug or any item on the clinical front needs to be brought into use, we can do that much faster than an organisation that's trying to do that with 2,000, 3,000 or 4,000 people and trying to get, because they're aiming for consistency across a much larger organisation. As long as we can absolutely assure our clinical governors that what we're trying to do, either in process or with equipment, meets their demand for clinical safety, and they give our trustees that assurance, then we can move very quickly indeed. And that means that we're always really at the front edge of what's possible to achieve for our patients.
Now, in my ignorance, when I first got involved with the air ambulance, I'd always thought that the air ambulance was a sort of standard ambulance that got there quicker, could get to more remote places, or could get people to more specialist hospitals quickly. But actually, the clinical model and what you can deliver is very different to that, isn't it?
Well, I'll leave Phil to describe the detail of that as it is now. But what I would say is that if you go back 10 years, you've actually described exactly what it was like. Because 10 years ago, we were operating with a 2 paramedic model, just as a double crewed ambulance would be recognisable anywhere in the country. Perhaps with a few more skills, practical skills added, but not much more than that. And at that time, the environment was such that four-wheel drive vehicles weren't as popular as they are now. So the ability for road crews to get places was much more limited. And so we offered both access and speed. But of course, over time, we have concentrated very strongly on developing our clinical delivery and the capability that actually comes with that platform, to the point now where actually the helicopter part is not, and this will sound really strange coming from a CEO of an air ambulance, it's not everything. What's really important is the capability that we carry to the patient. And Phil can probably describe that a lot better than I can.
Yeah, well, thanks, Bill. The ambulance services, NHS ambulance services across the country are really busy organisations, and they see, collectively, they see around 8 million patients per year. And that's on recent data. And what we recognise of those 8 million patients is a small number, a small proportion, are very sick or injured, so sick or injured that they may die before reaching hospital without very intensive treatment, or that their end outcome is worsened without very intensive treatment. And there is some national and international evidence for that being the case. And the estimations are that the percentage of patients that are in this critical care category is around 0.5%. So you can see that, across the country, it's around 40,000 patients, and then divided out amongst the regions, then you're getting down to smaller numbers. And it's very much at 0.5% of the entire ambulance service activity. It's very much a much smaller enterprise, but the effect and the significance for patients is really great because of the mortal risks that we're talking about. And what became apparent was you could have a regional clinical capability that could be delivered across a very wide geography, social and physical geography, by using an aircraft, and that model actually is one which we've pursued in Dorset and Somerset, and it's actually a model which is being pursued across now the majority of the country for supporting the patients across a very wide geographical area.
So who is actually on the helicopter then? Who would be attending a call?
So we have a nurse or a paramedic, and we collectively call them practitioners, and they have additional education and skills, and have really quite a significant exposure, ongoing development within critical care. And then we have a consultant doctor, and this is for Dorset and Somerset. We exclusively have consultant doctors actually who are either from an intensive care or an emergency medicine or an anaesthesia background, and then they work as a team with the practitioner to add on to the care already being provided by the ambulance service, to add on the additional elements of very intensive interventions to support patients to reach hospital, or to reach the correct hospital and bypass the local hospitals without specialist expertise. An example of that might be a patient who's been involved in a high-speed road traffic collision, and has suffered injuries to their head and has a reduced level of consciousness because of the head injury. And that can really affect your ability to breathe effectively. And in addition, high-speed road traffic collisions are associated with bleeding, and so these patients can have inadequate blood flow around the body. And so you can hear from that straight away that they're very severely injured, and that's the kind of patient we're talking about. And actually, in the UK, I should say in England specifically, we have a trauma system where very injured patients are looked after in centralised, regionalised centres called major trauma centres, and so Dorset and Somerset is able to attend such an injured patient, provide the immediate emergency management to optimise the patient sufficient to transfer them to the major trauma centre and allow them to then continue on their flow through their NHS journey in the hospital. And
just one point that Phil raised there and mentioned, he talked about this team approach, and it's important, it's certainly very important for us that at the very genesis of us having this critical care team, the word team was absolutely core to that. There are models, and there were models then, of paramedic-led activity, doctor-led activity, etc. We were determined that we would bring the best of all those professional disciplines together and harmonise them properly, so that we could deliver the best possible critical care that was available at the time, and we've continued to develop that way. And it is really core to our whole ethos as an organisation. It's amazing watching. I have to say, as a lay person, watching it in action, not live, I hasten to say, but seeing the results and also watching them going through simulations is, for me, as an ex-serviceman, an object lesson in how teamwork can really, pardon the cliche, you get more than the sum of the parts, and it's writ large in what they do, because you can see this team who have practiced together, worked together. There's no ego, there's no hierarchy. It's all about focused on the patient, and each picks up their part in that whole treatment at the right point as they go. And there's no need for that. There's no dividing line between our practitioners or our doctors. And more we actually find that the crews in the front of the aircraft, the pilots, are playing a part as well, because often they're dislocated. The patient is actually dislocated from the aircraft because of landing restrictions, and you can't ensure that you've got everything with you when you first go. And then once you're with the patients, you can't leave them. So the pilots end up bringing, what's required. They're called up and bring what's required on foot to the patient as well. It's a beautiful thing to see. I can tell you that.
And presumably, what you're asking of the people who are involved in this is quite different, or can be quite different to their day job. So you offer some training and support around the extra skills they need.
Yeah, it's a good point. So that we have, for our practitioners, some of our practitioners work full-time within pre-hospital care, and some work part-time within pre-hospital care and then within hospital care, for example, intensive care units in hospitals or in emergency departments. And we've got a mixture of clinicians with those job plans. And actually on the consultant side, as you say, we also have a mixture that part of their job is working inside hospital and part of their job is working outside the hospital. The clinical skills that they are applying for to patients are the same. The context is different, and certainly the context can be quite challenging, very noisy, cold, raining, But once and Bill picks this up with the effect of teamwork and practicing together, then actually many of those environmental challenges fade into the background, and the patient's clinical needs come more into the foreground, mainly through practicing, and the same type of medicine then can be applied to the patient that the clinicians are involved in all aspects of their work. So in that respect, we've have a framework for minimising difference and maximising the opportunities that come through standardisation. And of course, every patient is different and every circumstance is slightly different, and so we also empower our teams to make judgments, which they do together. And as Bill says, they're very good at that. And of course, we work very closely within the ambulance service, the NHS ambulance service, and our colleagues on the ground, looking after the patients that we come to join in with, are a great source of support for achieving what we all believe the patient needs.
I think if I may, Sarah, just to make a point, and it really it goes back to my point about what this enterprise costs. One of the costs which we guard really jealously is the resource that enables us to do the activities that aren't necessarily patient-facing. We have built our team around a structure that accounts for governance activity, training activity, education, and extra training in the form of hospital placements and so on. And all of that, of course, adds to the resilience when you meet extreme challenges, as we have done in the last couple of years. So I think that's something which goes back to your point about why we'd rather be independent from the NHS, because it enables us to really come to a point where we can deliver that and invest in the individuals to a level which, in all fairness, I'm not sure a government department can ever really manage that, because the bill would just be too high. So the size of our organisation enables us to look at what part that plays in the overall delivery. And I'm pleased to say that when we have our monthly training sessions with the crew, and of course that's not just our crew, as Phil pointed to there. Often there are ambulance service personnel involved in that, fire service, police, because this collaborative effort that goes with not just us but with our other emergency services colleagues is also important, because you don't want the first time you meet these people to be at a scene. You want to know what they're bringing, how they're going to react, and what they can add, how they can add value to the outcome of that patient. So and that comes at a price. So that's something which, on as a CEO, I absolutely see adding value, and will protect that as best I possibly can.
Excellent. And I guess that liaison in quiet times, as it were, means that people know when to call you, when it's appropriate for the air ambulance to be involved. Is there a way that you decide where you're going, or which calls you accept, or is it just everything?
Yeah, I think it's a really important question, and across the world, health systems haven't mastered the ability to task specialist resources in a perfect fashion. And so it's an ongoing challenge for all health systems across the whole world, actually, to both civilian and military, to be able to recognise patients who are in this small percentage and have critical care needs, to then mobilise the specialist resource, and in a fashion that is accurate with and picks up all the patients that you want to pick up and misses all the patients you don't, and it's simply impossible to achieve all of those things. And so we have a system, and the other thing is equity as well, actually. And so we actually have a system that's based within the ambulance service, and so it's the NHS that determines which patients our skills are going to be utilised to support, and from a patient-to-patient basis. And collaboratively, we work year on year to try and improve the framework that mobilisation is achieved within.
There are two aspects to that. One is a technical function, and the other is an educational one. The technical function is actually, I say technical, it is human, but it's where do you get that information from that you're acting upon? The desk, in our case, that sits in Exeter, because it covers the whole of the Southwest Peninsula, is monitoring calls from all over the peninsula, and the helicopter desk that sits within that is trying to cover it all. So there's your first challenge. That's a huge bill to try and meet.
And these are 999 calls, Bill.
Yes, these are 999 calls, because I should say that the regulatory background to this is that our patients, we refer to them as our patients, but actually they are ambulance service patients, because they're the authority, and we can only attend having been tasked by them. We don't have, the CEA would not give us authority to fly around the countryside and land wherever we liked without that authority. So we have to meet that requirement. But the first part is this: how do we get the information about a patient through the system back to the desk so that they can task us? But the other part is how the humans at the front of this, how do they know whether you need critical care or not? I mean, how do they judge that? And that has been a really interesting development of ours, which is we've developed an outreach program, which is designed, is centered around trying to educate, is perhaps too coarse a word, but actually just explain what critical care can bring to that patient when they're required. Because every ambulance person wants to do the best for a patient, but if they don't know that actually calling for the air ambulance at that point will make all the difference, then they'll struggle they'll continue doing the best they can, and it may not be in the patient's best interest. So we've had a few years at this now, and we've seen definite improvements in our tasking as a result of that. I mean, the numbers of people we attend now who definitely needed critical care, as opposed to, well, perhaps an ambulance could have done that. That balance is shifting. It hasn't gone away altogether, and nor would we wouldn't want people to take chances with that. We would rather, and I'm speaking for Phil and the clinical team, they'd rather be sent to someone who ultimately didn't need it than that patient. Than the other way around, i.e., they didn't get sent and that patient really did need it. So we'd rather err on that side of the equation.
And how often do you get called out, just out of interest?
Well, the number of incidents, call-outs, I mean, if you go to last year, for instance, we attended around 2,200 incidents. Now, a number of those incidents actually didn't result in us treating any patients, because like all systems of this nature, emergency systems, there are call-outs which then are stood down fairly quickly, because a number of factors. Either the patient could die before we were on scene, the ambulance crew in the first instance, then realise the patient isn't as bad as they thought and they can deal with it, and so the helicopter will be stood down, because their interest is actually maintaining us on call for the right patients. So they are always looking at that aspect. And the last is sometimes the crew on the ground, the circumstances are such that they really feel it's in the best interest of the patient to run with the patient to hospital. In which case, we would be stood down as well. But and that figure of stand downs to actual incidents is pretty even across the country, interestingly, and it centres around the 20 to 25% of admissions, which may sound high, but actually it's been around that figure for a long time. There have been peaks and troughs, but that's through for other reasons. But around 20 to 25% is pretty much the norm across the country.
I just want to ask you about some other bits, sort of moving away a little bit from what you've been talking about. But one of the things that you have, which perhaps the ambulance service doesn't, is the family liaison, is knowing what happens afterwards and having that continuity. Can you tell us a bit about that?
We've both got an angle on this. I'll give you the organisational one, because that's the cleanest. From an organisational perspective, and this is with a business hat on, looking at the function of that function, its core purpose was to refine what we're actually achieving through our patient-facing critical care activity, so that when the patient leaves us, we can track the patient and the people who are treating that patient and get feedback as to what we might have done better, what we might have done more of, what we didn't need to do at all, and so on. And that's a cycle which most people would recognise is a requirement for continual development. The reason that we've gone the route we've gone by employing nurses is that it's a reality that getting that feedback from hospitals is challenging for a number of reasons. First of all, there is patient confidentiality, which of course has to be protected, but also there's people are just very busy, and they don't want to be bombarded with calls from people saying, I left the patient with you last night, how are they doing? And they're not always up to speed themselves, even within a hospital, as the patient tracks through hospital. So having a nurse in that role who understands how hospitals work, they have a far more collegiate approach when they're working with hospitals, and can gain that information by asking the right questions in the first place, which helps, but also by being trusted to deal with that information properly and with due respect. So that's why we went through this process, and why nurses were considered to be a good business decision. Now, interestingly, the benefits that they have brought have been immense and way beyond that. The patients themselves, and I'm talking from my side, where I see the thank yous coming back from patients and families for the information that they've been able to glean from our patient and family liaison that previously they just would not have been able to get. And in circumstances where you wouldn't expect to be getting much information. One particular aspect which we sort of knew might happen but didn't realise how powerful it would be is when patients don't survive. And what has happened in the past, of course, is that often they're sort of forgotten then, because the NHS has to move on and is caring for the next cohort of people coming through, and our patient and family liaison nurses actually can get alongside those patient families and loved ones, and explain exactly what happened and what was done to try and change that outcome. And we've had some amazing responses from those families, thanking us for the service that's provided, and they know that we've done the best we possibly can for those patients. Now, callously, you might say, well, that's really good because that does your fundraising no end of good, and there is a bit of that, but that's not really why we do it. But in the clinical sense, I mean, Phil's in a better position to answer exactly what they can do to aid the clinical journey of the patient.
Yeah, thanks. We've been looking at the pathway for patients from end to end. So as it happens, and we could come to later, prior to people becoming patients, but then once they're recognised to be a patient, then we have tried to support their various pathways through our critical care service, and then into the hospital as best as we can, and to make that flow into the hospital smooth. And the patient and family liaison nurses that we have working with us are really excellent communicators and clinicians in their own right, and are involved in supporting patients and families after they've received critical care from Dorset and Somerset Air Ambulance. And there's this is the worst day of the patients and families' lives, and mostly never to be repeated. And actually navigating your way through that is very challenging indeed. Not least that the hit of what happened and the whirlwind of what happened in the pre-hospital section of the journey for the loved one or themselves is not understood, because it was a life-threatening event, and their memory of it is poor, or it was very confusing because there were so many things going on, or indeed they were so critically ill that simply there is no memory of the event. And then our patient family liaison nurses are able to help with piecing the jigsaw, which really helps in the onward recovery process, piecing the jigsaw together of that stage, but also linking them to colleagues and other charities and other services which we know can support patients and families through their journeys. And one example of that is developing a peer support network of patients who have, for example, had a particular type of injury and flowed into the trauma centres, and then received the excellent care that they have from the major trauma centres, and indeed the follow-up care that they receive, and then come back to be local to their local centres in Dorset and Somerset. And our patient family liaison nurses are able to support that transition and the joining up of the dots, and joining up to other patients who have gone through this already and survived through it. And so the hope that provides to families and patients that this mountain for them to climb has been climbed by someone else who's willing to talk to them, and they've been through very similar life experiences is an astonishing capability. And our two, Joe and Kirsty, our two nurses, have been working very hard in developing that resource. And that's another element of the kind of navigational support that they provide, both surviving patients and their families.
Unfortunately, it's not a case of ours. It's a case of a chap who he's the patient and family liaison person for London, who has acted as a mentor for our patient and family liaison nurses. He describes a case where a chap, sadly so badly injured, was paraplegic, still in hospital, but actually thought that was the end of it for him, that life was just not going to he just wasn't going to be able to cope with life at all. And he was in such a way that one of the London Air Ambulance's other patients was asked to come and talk to him. Imagine the moment when the patient is in hospital feeling very, very sorry for themselves, and rightly so, when in bustles someone quite late for their appointment in a wheelchair, and the first thing he says is, "I'm sorry I'm late, I had a real problem parking the car." It was one of those eye-opening moments, and it did, and that the conversation that ensued from there was wholly positive and practical, but that sort of moment, we could paint a similar picture for someone in a small village in Somerset or Dorset who has a life-changing injury, and having gone through the amazing system that Phil's described, both the hospital, recovery, rehabilitation, and so on, thinks that's it. Their life has fallen apart, and because there's no one else in that village has ever suffered in the same way. Well, we now have a network of people who are probably likely to have suffered quite similar injuries, and can offer that sort of support. So it's a powerful tool, but it's not us trying to replace something that already exists. It's just joining dots on behalf of the patient.
And you do quite a few other things as well. I think Phil referenced it when he was talking just now about trying to prevent people from becoming patients in the first place, which isn't something I would have thought an air ambulance was really thinking about. But what do you do in that space?
Well, I'll start by saying that actually you're right. It's not something you'd think an air ambulance would do, but a charity should. A charity should always be looking for the circumstance where it's no longer required, and that should all be our goal. And actually preventing injuries that require our service, injuries or illness that require our service, should be our goal. So if we start from that point, then Phil can describe the prevention activities that we undertake.
Yeah, thanks. We certainly, that's a very powerful case that Bill describes from the charity's perspective, and from the patient's perspective. We as an organisation exist to advocate for patients and families, and it would make sense for us if we had inside knowledge about why and how and when patients become, for example, injured, is a really obvious example, and then the consequence of those injuries. It would be really obvious for us to wield that knowledge to try and prevent them becoming injured in the very first place. And so that is something that we're really passionate about, and have a developing programme of injury prevention within the domains that our clinicians support patients. Certainly the NHS are talking more about preventing injury and illness, but particularly illness actually in the current discussions. And it just makes sense for a health system to promote health rather than just patch up and support a disease treatment. Our clinicians themselves have a real witness to describe to policymakers, to the public, to other health professionals, and that is that they've held the hands of some extremely sick and broken humans, and they feel passionately about helping them, and they have been able to, and sometimes they're not able to, and despite their best efforts, then patients die, and so the emotion associated with futile loss of human life in a circumstance that you feel is preventable drives very significant passion to try and stop these things happening. And certainly the most overt of those is motor vehicle accidents that we attend, that I was describing earlier.
I should say one of our doctors he works in for Dorset Police. He's been a doctor for Dorset Police as their medical lead, and he runs an organisation now called DocBike, which started its life as an education tool, really. He would attend bike meetings, motorcycle meetings, and because he wasn't a policeman, he was given probably a voice that might have been otherwise hard to achieve. He wears, his red suit when he can, but actually he's obviously in motorcycle kit most of the time. But the point is, he's there to educate bikers about treatment of their friends if they're involved in accidents, if they're riding in a group and there's been an incident. That was how it started, with the aim of then feeding that thirst for knowledge by pointing them towards bike safety courses so that they're safer biking. And over time, they've managed to prove that is effective at reducing the number of motorcycle incidents in Dorset. That's now spreading. He's trying to go nationwide. It's a slow burn in lots of parts of the country. But the governance for the medical activity is currently through the ambulance service via us. And we support that activity very strongly. And he's a great advocate for the Dorset and Somerset ambulance, but he's also, as I say, a vanguard in one area of our prevention agenda as well. We have another doctor who is similarly involved directly with road safety in a more general context. We have agricultural incidents, which for a rural operating air ambulance feature quite highly, as you you'd probably guess, and that. So Farmer Down is another of our preventative activities. It's trying to encourage farmers towards behaviour which often seems alien to them, and that is, take more care around agricultural machinery because it will bite if you're not careful, which sounds a bit patronising, but it's true nonetheless. And also with water safety. So bit by bit, we're trying to cover the quadrants where the worst of the injuries that we're facing actually come from.
And I could add to the water safety bit, and really actually across the piece, that there are existing very high profile activities for prevention within each of these domains, and we're collaborating with the lead organisations, and so the RNLI and our Coast Guard colleagues would be two obvious examples within water injuries, and so our intention is to support those critically ill and injured patients, as it happens within Dorset and Somerset and within the broader southwest on behalf of the ambulance service, and to get to as many of those patients as we physically can through better tasking and having a resource available for them. And we'd really love for them not to exist. And if we were able to reduce down those numbers, there would be a total joy to us.
I just want to ask a quick question going back to resources, really, and the NHS. And obviously, there's lots in the news all the time about the pressures on the NHS and the activity that's ramped up and so on. Does that impact you and what the air ambulance can do?
Yes, it does. We've been very successful in our fundraising over the years. Let's talk firstly about money, and then people will talk about slightly separately. But in terms of funding, we've been very fortunate. That's not to say we haven't worked hard at it, at building the level of resource that we can bring to this problem. And so over the years, we've managed to build a stockpile, a reserve in the parlance, which every now and again along comes the rainiest of days, and we have to raid it. Interestingly, the last 2 years, when everyone thought that we would be hit hardest, we were hit, but not hit so hard that those reserves have had to be raided, which is all to the good. But it's meant that we've continued on our developmental path. We haven't had to sort of hunker down and just stay where we are because of lack of resources. Now, the lack of people does come to an issue, and I've said we build in a more robust and resilient team size to cater for all the governance and so on. But interestingly, during the last 2 years, and particularly the last year, that has been tested in the extreme, and some of our planned activities have had to just stand by whilst we met the real challenge. For instance, during January and February last year, when the inter-regional transfers of COVID patients was being undertaken, at a time when it was a national issue that had to be addressed. And I'm really pleased to say that we were able to stand up a team, and a fully equipped team, to support that activity. And out of the 23 inter-regional transfers that were conducted nationally, we did 12 of them. So we were able to do that because of the resilience we built into the team anyway. But we couldn't have gone on for too much longer doing that without actually jeopardizing our 19 hours a day, 365-day a year service, which coincidentally never dropped. It was touch and go, though. I think that's fair to say, Phil.
I mean, it was certainly hard work from all members of the team to be able to step up to the crisis that the country was facing. But we were pleased to be able to support with our specialist service and to add to the whole nation's response to COVID, and to get through it together. So I think it's this has been a challenging 2 years for the health service, as has been dramatically demonstrated, and with the enormous number of deaths, and we've certainly been able to contribute to the NHS response.
Now, at the end of last year, there was the National Air Ambulance Awards of Excellence, and I know you both won individual awards. I'm not going to embarrass you asking about those, but I'd like to just pick up on the third one, which you won for the Innovation of the Year award. Could you tell us a bit about that innovation and why it was recognised as being of national interest?
I think it's quite helpful to ask who's the sickest patient at any one time in the region, and actually, interestingly, given that we've been talking about patients outside of hospital, sometimes the sickest patient in the region at this moment is in a hospital needing surgery which can't be provided in that particular hospital, and therefore needs to be in another hospital. And that can be the case for brain surgery, and for in children's cases, specific paediatric surgery, and those are very obvious examples where a patient may be in the incorrect location for their ongoing care. And some of this surgical demand can be emergent. So that is to say, if they don't receive it rapidly, then the patient can die or have a worse outcome. And for children, this is also the case, that they have emergency needs and may be in a hospital which doesn't have the specialist capabilities. And we actually do have regionalised children's hospitals, and so that we have one in Bristol, and then we have one in Southampton. And those are the two hospitals that cover the south of England and the southwest, and for children's services. And when a child who's critically ill or injured and needs to receive rapid, particularly surgery in the regional hospitals, needs to be moved, then that is a significant challenge to the whole health system. And so we recognised with our colleagues in the hospital systems that we could support the movement of these patients. We have a team that are well trained, that are NHS governed, very well equipped, trained together as we've been discussing earlier, and can mobilise on an immediate time frame in an aircraft which has a long range and is fully capable of moving critically ill children, because that's something we do when they're on the street or in their homes, and so we can turn that to moving them between hospitals. And so we worked on that for actually 7 years to really build the capability, make sure the teams were absolutely trained up to a standard which was equivalent and accepted by our hospital colleagues. And we worked in collaboration with the existing specialised paediatric transport services that exist within, based out of Bristol and based out of Southampton for the regions. And as an end point to all of that work, we began at the request of the regional paediatric transport services that we started moving patients that we call, and they call, time critical. So time critical children that need to be moved on very promptly and safely in a governed system to receive urgent specialist care. And so as a big collaboration with the services called Watch, the Wales and Western Acute Transport Service for Children, and SORT, Southampton Oxford Retrieval Team, which are the regional transport services, in collaboration with them and under the governance of the ambulance service, we began moving patients, and just in the year 2021, the calendar year, we moved 15 time critical children at their request to support the child and the parents and the regional system. And it's been a privilege to be involved in those pathways, and looking forward to continuing to support the region in this fashion.
As of then and now, we're the only local air ambulance that actually is accredited and able to do this. But it hasn't happened by accident. It's been a 7-year journey to get to this point, and it was a determination, I say, 7 years ago that local ambulances could possibly do more in the inter-hospital transfer of paediatric cases. You may be aware, and many people will be aware, of the Children's Air Ambulance that operates out of the Oxfordshire and north of there, but and covers the whole country. But my view as an ex-aviator, was that we shouldn't have to wait for 6 or 8 hours for an aircraft to come from the middle of the country down to this part of the world to do something which majority of air ambulances probably could be capable of doing anyway. Now, that was a very naive view of life on my part, and the fact that we're the only ones so far who have taken that up probably proves how naive that view was. But the route there was long. There were technical issues, there were human issues, and the biggest issue in the end is actually proving that you meet the required standards to do the activity, and that's the hurdle which is most difficult to get over, because it is incredibly demanding. We talk a lot about the health economy and the impact that we can have on the health economy. And if you go back to that last example where we provide almost, it sounds blunt, but a turnkey solution to a problem. We're not denuding the NHS of any resource at any point in order to make that happen. And we think there are other areas that could benefit from that. I mean, one area, of course, is we've talked about paediatrics. Well, what about adult time critical care retrieval? There are organisations out there, NHS and commissioned organisations out there, but they don't have a limitless resource. And I just like to make a plea to all parts of the NHS to look wider than the obvious line that's right in front of you, because there are organisations like us who will be only too willing to step in and help in circumstances like that. And I think sometimes it's really hard to break down that barrier. It's through the ambulance service. It's straightforward, but sometimes even they are not in a position to. They're not asked the same question. So it's really it's spreading the word really. That our view is that the health economy we need to add value to it, not to take things from it. So everything that we do is aimed at doing so without actually denuding an acute trust, for instance, of critical staff at a time when they probably need them most.
And I think it's really easy, isn't it? Within the NHS, there's so many pressures and demands that you can start to focus just on that little bit that you are responsible for, and not really think beyond beyond the boundaries of your organisation to what else might be possible and who else might be out there to support. So that's a really, really good point. Thank you both so much for your time, and I hope that people have found this useful and you'll be making some inquiries of their own local air ambulance and trying to find out a bit more about what goes on in their own area for those who aren't in the Dorset and Somerset region. Thank you.
Thanks, Sarah.
Thanks, Sarah.
Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.